Apologies. Good afternoon, everybody, and welcome to our lunchtime webinar. It's absolutely brilliant to have you all here this afternoon for our first webinar of this financial year. So I'm absolutely delighted to be welcoming Professor Sanjay Agrawal here today for our joint Fresh and our North East North Cumbria NHS ICB Smoke-Free NHS programme. So we do these webinars together. We have them every quarter. We have them over lunchtime for an hour. And it's your opportunity to really hear from world leaders in terms of their expertise and to ask any questions that you may have for the speakers and to really take away the learning that you've learned from the specific topic and think about what it means for you, your practice, and you know, any thoughts for the future. Just to do a quick little scene set in terms of why we're here today. You know, the importance of these webinars and the importance of the programme and your brilliant work locally is that, you know, tobacco remains, despite the fantastic progress this region has made, still our biggest driver of health inequalities. And it's, you know, quite, you know, shocking to think it's been nearly 8 million lives have been lost to tobacco in the last 50 years, you know, 26% of all deaths. And I know in the Northeast, all of us will have had somebody really close to us, our loved one, that sadly died from getting hooked in childhood to smoking and dying from a completely avoidable smoking related illness, including my own dad, who's there top left, who died just at the age of 61. Those of you who aren't familiar with Fresh and Balance, we're a regional tobacco and alcohol programme. We're commissioned as Fresh across the whole of the region to deliver a comprehensive regional programme at population level, which recognises that there is no single magic solution, but we need to be doing lots of different things comprehensively, and that's set out in our 8 strands work of Fresh. We also very much recognise that smoking is a chronic relapsing long-term condition, and we are very mindful that at the heart of a lot of our planning needs to be that person who smokes to ensure that we are doing all of the things to reduce uptake of smoking, but really importantly, maximising as much as possible as many opportunities for quitting, which can come through a whole system approach to ensure that every year we're supporting people who smoke to make that annual quit attempt and to ideally give them the best chance to quit by giving them the optimum amount of behavioural support, medication, etc. And we have a whole work programme in place around that, which includes NHS and local authorities. Now, in the North East, we've got a very clear vision of the future. You know, we're very fortunate to have such strong vision from across many leaders, which has been there for the last 20 plus years since the Fresh programme Working with Everybody was launched. But we're not going to let up. You know, we support a smoke-free future free of the death and disease from tobacco. And this is set out in our Declaration for a Smoke-Free Future. Through everybody's collective work, this region has achieved the biggest drop in in adult smoking rates of any other region in England. In fact, a 65% reduction, with smoking rates overall down to a record low. However, within that lies a huge amount of disadvantaged and certain groups that have got much higher smoking rates. And also within our prevalence surveys, we are, you know, missing people who are actually smoking. So I guess the key message, and we'll hear from Sanjay, is there is absolutely no room for complacency. There is still a huge amount of work to get done. And today's speech, then, I'm going to hand over to Professor Sanjay Agrawal. I've been honoured to have worked with Sanjay for a number of years now. He is here representing the fantastic new report from the Royal College of Physicians, which we're really proud to have played a part in, particularly Catherine and her expertise around illicit tobacco. But Sanjay is going to bring to life the brilliant report, Smoking, Health and Social Justice. Sanjay absolutely knows what it's like to be on the front line as a consultant in respiratory and intensive care medicine, and to see, you know, what the repercussions are when people do get addicted to tobacco products. So without further ado, I'm going to hand over to Sanjay, and just to say that this webinar is being recorded. So just the presentation will be then uploaded to our YouTube channel and also into our Groups on K-Hub. While Sanjay is speaking, please could you keep your microphone muted? And also, as always, please be respectful of colleagues on the call, but we, you know, a wide variety of opinions are very much welcomed here, and you sharing your experiences. So please use the chat function. We'll be monitoring this. And then there'll also be opportunity to put your hands up when Sanjay's finished to ask specific questions. And at the very end, I'll do 2 or 3 slides just to wrap things up. And we would really welcome your feedback from today's webinar. And as always, these are your webinars, so you let us know of topics that you would like us to put lunchtime sessions on for. So thank you, Sanjay.
Brilliant, thank you. So I'm just going to share my slides. So there we go. Can you just give us a shout out? Can you see the slides?
Yes.
Okay, Elsa? Yeah, brill.
I
Okay,
can.
and then just tell me if it moves on. Oh, there you go. It's not going to move on. There we go. If I press that, there we go. It's moved on.
Yes.
Yep. Okay, brilliant. All right. Well, firstly, thanks, Elsa, Joanne, Catherine, for asking me to come along today. I'm always very jealous of you all in the Northeast because you work collectively, you focus on what's important, and you get results, and it's very visible to everybody. I live in the Midlands, and when I look at our smoking prevalence and compare it to what you guys have achieved in your patch, we're not doing well. And I wish I could clone you and import you all into the Midlands. But anyway, that's a conversation for another day. So today I'm representing the Royal College of Physicians. And just so you know, if you don't know, this is a membership organisation. There's 30,000 members across the UK and around the globe. And our mission as a Royal College is to improve the health of the nation. So within that, we have public health and prevention groups, and I lead the Tobacco Advisory Group. And every 2 or 3 years, we produce a report on tobacco control, looking at one facet or the other. And we've just published our most recent report, which is called Smoking, Health and Social Justice. And it's really to look and focus on the disparity in smoking prevalence within and between populations, predominantly in England. And that's what I'm going to go through. Now, when we start preparing these reports, there's about a 2-year lead time from when we come up with the idea to when we publish it. So we first started thinking about this report in 2024, and we've just published it in May of this year. So the context at the time when we started to think about the report was that smoking prevalence has come down, which is brilliant, across the nation, and it's at an all-time low. But the problem for that is that people will think that the job is done. But just because something's low doesn't mean it's not gone. And there's still a lot for us to do because of the harms that we see. And in my job as a lung cancer doctor in respiratory medicine or in the intensive care unit, where I see people with smoking related diseases, I know the job's not done because I still see it. I've got a clinic this afternoon and I've been through the clinic list, and at least half of the people I'm going to see are still current smokers, and they're coming to a lung cancer clinic. So clearly we missed the boat many years ago with treating tobacco addiction in the people that I'm seeing this afternoon. So that's one part of the context. The job is not done. The second part of the context that we thought about 2 years ago was the Tobacco and Vapes Bill was going through Parliament, and it's fantastic that it's now legislation. But because of that, there's a unwanted complication, which is, again, people will think that the job is done. It's used all of the political capital it had getting the bill through Parliament, and therefore there's a deprioritisation. The third context is, as a country and around the world, there's lots of financial constraints. The NHS is getting record levels of funding, but we know that there's, rightly so, the country is needing to cut its cloth accordingly, and there's financial pressures on the NHS to reduce its budget, also in local government. And also there's a change in the political landscape, and different governments and different councillors may have views on prevention and tobacco. And so that's another context with which we wrote the report. These are the things that we were aware of that were happening. And that's why we thought landing a report on social justice might be helpful at this time point. So the purpose of the report was to describe the variation in smoking prevalence between UK population groups, because the averages hide the disparity. We know that although national prevalence is just over 10%, actually different population groups have got significantly higher smoking prevalence. We wanted to explain to people why there's drivers of this variation. Why is it some groups have much higher smoking rates than other populations, and therefore what is it we can do about it? And they're focused around the wider determinants of health. We wanted to expose the hidden population of people who smoke that are not captured by national data. So as well as having disparities, we also have people that are just not being counted. So we've got this false sense of security that the people that we're responsible for, that the job is done, that smoking prevalence is low, and it's actually not true. Then we wanted to think about the economic impact and the benefits to invest in smoking cessation services and tobacco control that would come to our localities and our communities and the nation if we really address this problem systematically. And we provide a number of recommendations that we think will promote that equity. So that's the context. That's why we did the report and what was going on at the time and is going on at the moment, and why we did the report. So if we think about variation by population group, just move that. This was published in January of this year. This is a graph of smoking from the least deprived groups to the most deprived groups. On the right is the most deprived groups. The men is in the darker colour, women in the lighter colour. And you can see between the least deprived and the most deprived, there's a threefold difference roughly in smoking prevalence. And for us, all of our population, so you in the Northeast, me in the Midlands, of course we have people in the least deprived group, that's great, but we also have a lot of people in our most deprived group, and that's where the smoking is concentrated. And so whilst the national average is around 10%, we've got big disparities in the places and the populations we serve. If we want to cut population groups in a different way, we can cut them by their settings or other risk factor use. So, for example, at one extreme, people who use opioids, or there's intersectionality, their smoking prevalence is around 90%. In people experiencing homelessness, it's closer to 80%. In people with serious mental illness, it's 40%. It's people in routine and manual workers, it's 20%. So again, you can see that there's a wide disparity. And you and I, we all live in places where there's a group of these people. So to think that everybody in the places that we live has a smoking prevalence of around 10% is not true. And we need to address the disparities and the populations who have the highest smoking prevalence, who come to the most harm. And finally, we can cut the disparities in smoking prevalence by some other factors. So, for example, educational attainment, those with a degree or equivalent, smoking prevalence close to 6%, those with no qualifications, it's more than 4 times that. Housing tenure, those who own their house, 7%, those who socially rent, it's almost 4 times that. And we can just keep cutting this by different population groups that demonstrate that there are many groups of people with a really high smoking prevalence, and we've got to do better in supporting those groups. So that's the first thing in this report. We wanted to expose the different trends in smoking prevalence and make the point that the problem remains, and we've still got a lot of work to do if we're going to have a fair and just society and have a level playing field by eliminating smoking and the harm that it does. So what are the drivers, though, of this variation? And we think of the wider determinants of health, and one way of thinking about the wider determinants of health are the social determinants and then the commercial determinants of health. So when we think about smoking as a behaviour, it's actually shaped by the places that we live, our employment status, the people around us, our age, sex, all of these things play a role into the likelihood of us smoking. So, again, many of you will know, if your parents smoke or your siblings smoke, you're more likely to take up smoking as a young person and then continue that addiction as you go on. If in your workplace, all of the people who work around you smoke, you're more likely to smoke. It's going to shape your behavior. If you're, so whatever population group you're in, it's going to shape your behavior. And the cumulative stresses of poverty, housing, employment, the more of these stresses you have, the more likely you are to smoke. Now, many people say, well, I can't influence employment, I can't influence housing. But what we can do is give people support where we've identified those population groups, for example, with employment or housing, and have focused programs to break the addiction to tobacco smoking that might then reverse that vicious cycle of some of these social determinants: smoking, poverty, and poor health. And then there's a commercial determinant. So unfortunately, we live in a world where there are many, many commercial actors who really don't give a monkeys about people's health. In fact, their entire profit model is that people use their products, and if they become ill, so be it. And that's really the way many commercial actors behave. But what's more insidious and really terrible is that many of these commercial actors will go out of their way to keep people hooked into using their harmful products. So, for example, in more deprived areas, you have a higher likelihood of there being retail outlets where people can purchase tobacco. You have tobacco priced in a way that's less expensive, not because the commercial actors feel sorry for people who have a lower income, but actually it's a way of making sure that they continue to smoke and use their products. So the commercial, and the other thing to say is advertising and appeal and luring people in to continue or to start smoking. Again, these commercial actors, the tobacco industry specifically, use new methods such as social media and influences to lure as many people, maintain that smoking behavior. So there's a lot of things that we can do to address the commercial determinants of health and also the social determinants of health, and we make the point in this report. So next, I wanted to just discuss another area that we tried to expose in this report is something called hidden populations. So the way that we describe national smoking prevalence is largely through government-funded surveys, the annual population survey or the opinions and lifestyle survey. And these are household surveys where they ask people a whole host of questions about all sorts of things, including the use of tobacco. The problem is you only get people who have a fixed address to answer these surveys, and also the type of people that will answer these surveys are usually by definition more affluent and able to answer surveys and likely to complete them. So you're only kind of asking the people where smoking prevalence is likely to be lower. When you start looking in detail at populations that are missed by these surveys, such as people in residential accommodation, be that in, for example, universities, detention centres, prisons, or populations such as sofa services, where people do not have a fixed abode, but they live with families and friends and move between different types of accommodation. When you look at smoking prevalence in those groups, it's much, much higher than the average smoking prevalence that is presented by national surveys. In addition, the national surveys, the way that they are asking the questions about smoking, might lead to underreporting of smoking, because they tend to ask about regular smoking, which can be interpreted as daily smoking, when in fact more and more people now are smoking intermittently, maybe every other day, possibly because of the cost of tobacco. So the point here is that we're missing probably anywhere between 1 and 3 million people who smoke in our national prevalence data, which means that we're underestimating the size of the problem which means in turn that we are likely to not allocate enough resource to tackle tobacco addiction. And therefore, we're going to perpetuate the problem and give ourselves false reassurance. So that's a really important area to think about. Another area to think about is intersectionality, meaning people with multiple risk factors. And so, yeah, here I am talking at a balanced webinar where you are focused on alcohol and tobacco. And if you look at audit scores, which measure, if you like, alcohol misuse, the higher your audit score, the more likely you are to be a current smoker. And I suppose if we had a graph of alcohol, mental health disorder, and smoking, it would show a similar pattern, and opioid use. So the more risk factors you have, the more likely it is you smoke. But this data is not reported in a national way where we follow trends. It's only due to some fantastic researchers at UCL and other places that bring these data sets together and report on them, some of which we put in this latest report. And then illicit tobacco, and I've got to thank Catherine and Elsa and the work that you guys do in Fresh, looking at illicit tobacco. And I apologise that the writing on this slide is fairly small, but you guys have been doing a survey on the use of illicit tobacco now for many years. And you're very unusual because most regions don't have this data, which is a real problem, because illicit tobacco can, in some populations, especially the more deprived groups, maintain that tobacco addiction. And in this survey from Fresh, from the 2025 survey, 21% of adults reported buying illicit tobacco, which made up almost 2/5 of their entire tobacco consumption. Almost 60% of children said that who smoked said they bought illegal tobacco, again probably because it's cheaper, and 2/3 had said they've been offered it, so it's easily, very easily accessible. They might not be able to buy it from a shop, and with the Tobacco and Vapes Act coming through, this will hopefully make that even harder, but there's still illicit means by which they're being provided tobacco. And these are largely with private addresses or tab houses, which was the place that most people got their illicit tobacco, but also pubs and clubs, as well as shops. So as a tobacco and vapes bill comes into force, it's going to be, I would imagine, somewhat tricky trying to police all of these places. Many of them won't fall into retail establishments that are formally recognised. 82% of illicit buyers said it made it possible for them to smoke, i.e. perpetuate smoking when they otherwise could not afford to, and that in general it was 2 to 3-fold less costly than legal tobacco. So why wouldn't you, if you had access to illicit tobacco, potentially, I'm not advocating for it, by the way, but why wouldn't you buy something that was 2 to 3-fold cheaper, especially if you're on low income? And more than half of the people who smoke and buy illicit tobacco are from more deprived groups. But interestingly, people who are from more deprived areas are not more likely to buy illicit tobacco than more affluent groups. So anybody who's offered a cheaper option will take it if they can get it. So this was really important work, and thank you all for doing that work, because it makes a difference. And again, it's an exemplar to other regions that this is really important, especially as we talk about localism and combining NHS and public services to work together in a more coordinated way. But all is not terrible. In terms of treatment of tobacco addiction, the new NHS long-term plan services introduced into hospitals shows that with opt-out treatment models where everybody's offered the same treatment, regardless of where you live or what population you're from, people in the most deprived communities, as measured by IMD, were more likely to start a quit attempt than people in less affluence by volume. because there are more people who smoke in those deprived communities, and you're more likely to be admitted to hospital if you're in a more deprived community. So actually the benefit is it's actually quite targeted when you offer opt-out treatment services in a hospital population. You are getting to those more deprived communities, and that's why it's so important to maintain our NHS hospital tobacco dependency services, because that's a key way that we can address health inequalities. So to summarize the information in the data in hidden populations chapter, it's very clear that national averages obscure large disparities in smoking, and you can cut it by protected characteristics or settings or whatever way you want, but there are huge disparities. And whilst the average smoking population and its reduction is great, just be very careful, because if you scratch underneath the surface, you expose all of these disparities. And the high prevalence groups are almost entirely excluded from national data collection. One thing I've not really focused on today particularly, but it is a problem, is all tobacco products such as pan and also water pipe tobacco users, especially in Southeast Asian populations. The data that we have is appalling. There's no systematic data collection on this, yet a significant proportion of our population are using these products, and many of them are just as harmful as smoking rolled tobacco every day. So we know that water pipe tobacco users get a really big hit, and again, depending on frequency, just as dangerous. And oral tobacco users get lots of different mouth cancers and digestive system cancers. But we have very little data collection on its use, and therefore how best to deploy resources to that group. As I've already said, we have regional data collection on illicit tobacco is very poor, although brilliant in the Northeast. And we could really improve our data collection if we triangulated data sources, if we use the annual population survey together with administrative data sets like the GP QOF data on smoking prevalence, like the NHS inpatient data on smoking prevalence. If we triangulated this data, we'd get much more accurate data on who's smoking, and therefore we can allocate resources. Because in the end, poor data collection affects funding allocation and evaluation of national policy interventions, and we need to do much better. We looked at the economic impact of tobacco use, and again, the data is really startling, and it shows that it just perpetuates poverty and disadvantage. So 1 in 9 people who smoke are likely to be unemployed, compared to around 1 in 30, 1 in 33 never smokers. So, and oftentimes that's because of ill health caused by tobacco. And it's important not to blame the person that smokes. It's really because we have failed as a community, as a society, to provide treatment and make it accessible to people who smoke from an early age, so that they didn't accrue the medical reasons why they may not be able to work. Around people who smoke retire earlier, around 3 years earlier, again, often due to ill health, and therefore lead to reduced household income and household poverty. And people who do smoke, again, because of health-related problems, earn less than people who have never smoked. And again, this perpetuates the cycle of poverty and disadvantage. And it's so easily reversed by offering opt-out treatment systematically at every opportunity. The annual cost of smoking to UK public services is around 19 billion. There's around just over 500,000 households that live in poverty because of the additional spend on tobacco, because of the addiction to tobacco, and it's that addiction that we need to break. And if we had a society where nobody smoked, that would put over £10 billion back into local communities, because people would spend that money in their communities. And it's estimated with the additional people who go back into work, it would add around £10 billion to the economy, including over 100,000 people who are able to work. Now, this is a busy slide, so let me just go through it. On the left is the forecast of people who smoke by IMD over the next few decades. And the national ambition is to have a smoke-free generation, usually defined as a 5% smoking prevalence or less by 2030. However, that's not going to happen until 2050 in women, and it's not even going to happen in 2050 in men, in the most deprived groups, on the current trajectory. So we need to do much more to help and support smoking cessation in our more deprived populations and groups. And on the right is a table that shows all the great work that local authorities are doing to really target smoking and deprivation based on where people live, people with mental health conditions, targeting people who are pregnant or in routine and manual occupation. So there's a lot going on, but there's more that we need to do. One final bit I need to just focus on is funding. So many of you will be aware that local authorities have been provided something called the Smoke-Free Generation Grant. It started in 2024, it's for 5 years, due to end in 2029, and it accounts for about £150 million, which is fantastic. The NHS also gets a funding stream between 20 and 30 million pounds to pay for the inpatient services and people being admitted to hospital who smoke, and to provide them opt-out treatment. And many of these patients will start in the NHS being admitted to a hospital. They're only in hospital for about 3 days, and then they get transferred into their local authority service. The graph on the right has shown the impact of introducing the NHS long-term plan. So it started out in around 2021, just post-COVID, and it's taken around 2 or 3 years to implement. And there's around 90% of all hospital trusts across maternity and acute and mental health trusts who now have an inpatient or maternity service. And that corresponds to the uptick in people coming through to local authorities around that time, prior to the smoke-free grant monies and the increase in that, that shows really that the pipeline and the footfall into hospitals of people who smoke, then going to local authorities, the two work together. And it's this duality, the combination of these funding streams that has worked really, really well to reverse the trend in visits to local authority that had been on a decline for many years. So I'd say that there's a risk that some people in local systems think it's a duplicate, when in fact it's not. They work together. The total is greater than the sum of the parts, and it's important that all of us try and protect that dual funding. And I know you in Fresh in the Northeast have in fact added to that funding, which is fantastic. So just to summarise, the purpose of the report was to reduce smoking-related health inequality, and we think that that can be done by wider introduction of opt-out smoking cessation services into all services provided by the NHS. So at the moment, it's just inpatients and maternity. Just to give you an example, it's around 20 million inpatient visits a year, whereas there's 25 million ED attendances, many of whom are not admitted. There's 100 million people who attend outpatients in hospital. And there's at least that, maybe I think triple that, who go to their GPs each year. And at the moment, the NHS opt-out services just doesn't include all of those other places. We're literally addressing just the tip of the iceberg and the people admitted to hospital. So we could do much, much more if we introduced opt-out smoking cessation into these other NHS settings. And the 10-year plan set out to do that, but it's yet to materialise by introducing services into ED and outpatient settings. We need to rebalance tobacco control policy so that we do more for the high prevalence group while still providing a universal service to everybody. We need to strengthen regulation on pricing, retail availability and marketing of tobacco products, i.e. addressing the commercial determinants of health. We need better data collection so that we capture these hidden populations so that we can really target our resources. And we need to think about intersectionality. So, you know, people who use alcohol, tobacco, unhealthy foods, gamble, there are some common risk factors here. And lobbying by industry to government bodies, for example, minimum unit pricing, working across government departments, including the Treasury, on tax increases. More of that needs to be done if we're going to affect smoking health and social justice. So I'm going to stop there, and then we can have a discussion maybe and think about maybe how we can influence this agenda.
Fantastic. Thank you so much, Sanjay. You did such a brilliant job bringing together arguably the best RCP report now to date. You know, with every report, I think, gosh, the next one can't possibly be as good as the last one, but it has been. So a huge thank. And I think it's a real sobering reflection, isn't it? Because I do think we have made collectively great progress, but if you've just absolutely perfectly shown us there is still more to be done, and there are huge risks as well if we think about the next few years in terms of the pressure on us as a community, as a system, whether it's at a locality level, if it's regionally, nationally, but also internationally, to keep banging on the drum that this is the most tangible thing we can do to address health inequalities. I will formally thank Sanjay for the most fantastic presentation, and we will upload your presentation, Sanjay, if that's okay, onto K-Hub and onto YouTube, because I think other people will really benefit just listening in. And I think there's a lot of reflections that we have as well. I mean, Sanjay, I think we need to be lobbying more in terms of the data gaps, probably. I think we've been a bit polite, probably. This is wrong, that we're missing a lot of people. So, sorry, I'm feeling a bit vexed about that. Do you think we do need to make more of a fuss?
I do, and not only that, but even the surveys that are there are being watered down or reduced in frequency, and we can't afford to do that as a nation. If we're going to improve our health, we need good quality data.
Definitely. Thank you. So I'll just whiz through a couple of slides, which at the end of these lunchtime webinars, after we international experts, I then just do a very quick little what's coming up, just so that people are aware of that and aware of other things that we've got underway. So Sanjay's already alluded to this a fair bit around the Tobacco and Vapes Act. It did get royal assent on the 28th of April. A huge thanks to everybody in the North East that ensured we got to that point, because there was lots of backwards and forwards and, you know, responding to things and keeping pressure on MPs, etc. We are covering this act throughout all of our different fresh regional forums, whether it's the Tobacco and Crime Regulation Forum, which is meeting tomorrow, the Fresh Local Tobacco Control Network, which is for our local authority colleagues, also through the Smoke Free NHS programme. So I think probably the North East colleagues are fairly expert on what is in this bill and what will also require further consultations, what will require secondary legislation. But I guess the big ticket item that probably has had the most profile is around smoke-free generation. Really important for everybody to be thinking about this, because actually the 6-month countdown to this is the 1st of July, because on the 1st of January next year it will be illegal to sell tobacco products to anybody born after 1st of January 2009. So I do just want to make sure everybody's very much aware of that. It's going to be a busy few months. And very important for the language around this. It's not illegal to buy, it's illegal to sell. And there is a lot of mischief making underway already by tobacco industry and front groups and things. But, we'll be covering this in all of the other forums. And then there are lots of other things in this act also, which are set out in here as well. There are other things that will give future regulations. So, creating powers around smoke-free places and extension of those. There still needs to be further consultation around the regulations around regulating packaging flavours in terms of vaping products to reduce appeal to children and young people, whilst noting Absolutely, vapes have played a really and continue to play a very important part in helping our addicted smokers to quit, including within NHS. So there's lots of other things that will be happening, and the Department of Health nationally will be leading upon a lot of this in terms of how the Act will be effectively implemented, including further enabling legislation and statutory instruments will need to be brought forward for that. And Catherine and the team leads upon all of the regulations side and does that brilliantly. Guidance will be coming out from the Department of Health in due course. We anticipate next month there will be the first set of guidance being created around smoke-free generation. And then also Department of Health in terms of communications and campaigns, just to reassure colleagues, we are very much advocating for things as soon as is feasible from the Department of Health. In the absence of the public facing campaign around communications around smoke-free generation, we're just going to crack on anyways and do as much kind of public noise around that as possible. So we've got a package going out for the 1st of July. It's the 19th anniversary of smoke-free workplaces. So why not also think about 6-month countdown to smoke-free generation? We will be talking through all of this tomorrow in way more detail in our 2-hourly online tobacco crime and regulation forum, which will have the Department of Health speaking at it, and also for their specific time slot, the Association of Convenience Stores, who will be talking through their Decline 09 campaign, which is specifically for retailers. If you're feeling a bit confused by all of this, don't worry. Ash, as usual, have got the most brilliant set of resources on their website. So there's one that's what happens next. So I would recommend you do have a look at that. So that's the Tobacco and Vapes Act. I've talked at the beginning around our regional declaration for a smoke-free future. You know, we launched that 2.5 years ago, but we also now have a refreshed national pledge for a smoke-free UK. I think this is very important. It's led by the Smoke-Free Action Coalition. It replaces the previous NHS pledge and the previous local government declaration. Please, 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 as an organisation, have a look at this. I think it's incredibly important to have as many local authorities, NHS trusts to sign this as possible, to show the political cross-party nature of this. You know, I was delighted when this launched in April that the North East Chamber of Commerce were one of the first in the first few days to sign this. And I think that shows how important it is that we make the case around the economy for this. So the details are on this slide. It's really vital that people don't think the job's done, and there are key specific asks to government. Just in terms of other things, so Sanjay talked about we need to show there's lots of ways to quit smoking. Couldn't agree more. We do now have the Fresh More Ways to Quit campaign. A huge thanks to the Association of Directors of Public Health North East for the additional funding, the brilliant collaboration with the commissioners in the local authorities. So this brings to life all of the different ways you can quit smoking, whether it's face-to-face service, it's varenicline, it's cytisinicline, it's NRT, it's the fact we've got smoke-free app. It's to get across the brilliant people behind the services. So this features all real people, real quitters, real advisors, etc. And I think it's vital that we really think about not confusing people who smoke further. And the more we can really work as a system, we're on the telly, we've got our Smoking Survivors adverts. So the more people can sign up and really signpost Fresh Quit as the regional portal for people to then, you know, get referred through to local services and things, because we're very fortunate to be able to run mass media hard hitting campaigns and then all of this. So if you don't know what this is, we've got resources, campaign toolkits, please flag. I've already mentioned that we're also fortunate to have this brilliant offer for health and social care staff. Please, please support this. Please help to promote it. You know, social care staff, a lot of them are employed in local authorities. They are often some of the poorer paid. And, you know, this is a brilliant offer that we've got in place, that we've got for them. It's got vapes and NRT attached to it. So please, again, we've got a campaign toolkit and promotion for that. And I can see there's somebody with their hand up, so I will come to that person, but also huge thanks for attending today. Your feedback's really important. So we'll send you this link, but also please do scan the QR code. It's only 3 questions. It takes 2 minutes, says Joanna. Fantastic. Well, thank you so much, everybody. A huge thanks, Sanjay. I'm pleased we got in first because I know you're a man in demand and lots of other places are going to be running these webinars, but you did a brilliant job. So a huge thanks. And we look forward to seeing people at the next Lunch and Learn webinar. We haven't got a topic for it yet. So again, this is your place. So do please flag to us. And thank you. Take care.